Ladies and gentlemen, now we move to the second agenda, Symposium 1 about tuberculosis. The moderator of the session is Mrs. Rina Triasih, PhD from Universitas Gadjah, Mada. And here it is the profile. Mrs. Rina Triasih graduated as medical doctor and pediatrician from Faculty of Medicine, Public Health and Nursing Universitas Gadjah, Mada. She pursued her master's degree in Master of Medicine Paediatric from the University of Melbourne, Australia. She also attended research and clinical fellow in Department of Respiratory Medicine, Royal Children's Hospital, Melbourne, Australia. Her doctoral degree was earned at the University of Melbourne, Australia. She was experienced in many tuberculosis research grants and programs, such as from Australia Development Scholarship, Stop TB Partnership, Department of Foreign Affairs and Trade Australia, and many more. Well, ladies and gentlemen, it's now my pleasure to invite the moderator. Please, Mrs. Rina Triasih, the time is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. It's a pleasure for me to be a moderator in this great meeting and a great session on tuberculosis, in which we will have three outstanding speakers: Professor Ben Marais from Australia, Dr. Philipp from Australia, and Prof. Ari Probandari from Indonesia. All three speakers will give the lectures for 20 minutes each, or approximately, and then at the end of the session, we will have a discussion. For that, I invite all of the participants to share your perspective or questions in the Q&A chat box, and then we will have discussion after that. Okay, for the first speaker, I would like to introduce Professor Ben Marais. Professor Marais is a pediatrician and infectious diseases specialist which is interested in global health. He is renowned for his work on childhood and multi-drug resistant tuberculosis. He serves on the executive committee of the NHMRC Center for Research Excellence in Tuberculosis Control and is a co-founding member of the Australasian Tuberculosis Forum. Professor Marais strongly advocates for Australia to take a leadership role in coordinating enhanced TB and MDR-TB control efforts in the Asia-Pacific region. More broadly, as a co-director of Sydney Infectious Disease, he works toward creating a dynamic multidisciplinary research community in infection, immunity, and biosecurity. Professor Marais trained as a pediatrician in South Africa and worked in the UK, the Netherlands, Canada, and the United States. And he already had hundreds of publications, and one of the great publications is about the description of the natural history of childhood TB from the pre-chemotherapy literature. Professor Marais will present the lecture about innovations and advances in child tuberculosis diagnosis and treatment. So please welcome Professor Marais. It's time for you to give the lecture.
Dear colleagues, thank you for the invitation to talk to you today about innovations and advances in TB diagnosis and treatment. I'm talking to you today from Seoul in a hotel room here at the ACPIT conference, but I'm very grateful to join you in your meeting. Quickly reviewing the global burden of childhood tuberculosis, I'm showing some data from 2020, the 2020 Global TB Report, reflecting on the 2019 situation, because this was pre-COVID. You're all familiar that there's a huge global disease burden, estimated to be about 10 million people per year, of whom more than 1 million is estimated to be children. Importantly, of the 1.4 million people who die from TB every year, more than 200,000 are children. 80% of these deaths occur in children under 5, and 96% of deaths occur in children who haven't had access to TB diagnosis and treatment. On top of that, we need to be very aware of the impact that the COVID disruption has had. Globally in 2021, we know that TB notification rates dropped by over 20%. And in Indonesia, you may very well be aware that TB notification rates dropped off considerably, the blue line here, and stayed low, which is a major concern. And I'll just show you some of the impacts that we are worried about. This study documented the COVID impact in Spain in 2019 before COVID and 2020 during COVID. Numbers are not large, but it demonstrates the principle which I think was observed in many other settings. First of all, at the bottom, you can see that adult TB patients presented with more bilateral lesions in the chest and with higher rates of cavitation, suggesting that they've had longer diagnostic delays. And that is also suggested by the fact that children in these households had increased rates of latent TB infection. We often think that COVID protected us against TB because people were wearing masks, but often inside the household, people were not wearing masks, and clearly access to TB treatment and care was greatly compromised during this period, which impacted on household transmission. During 2022, WHO launched a new operational handbook on tuberculosis, which emphasizes the complete TB care pathway from exposure all the way via infection to treatment if diseased, or to preventive therapy if detected prior to disease. This new operational handbook with the accompanying guideline is a wonderful resource that is available online, and the most complete set of guidelines that's ever been developed by WHO for childhood tuberculosis. We cannot talk about childhood tuberculosis without considering the persistent gaps. The gap in TB prevention. We know that more than 2/3 of children who are eligible for TB preventive therapy under 5 years of age did not access preventive therapy in 2020, and numbers are very similar for 2021, even larger in some settings. And we also know that there's a persistent high case detection gap, with less than half of all estimated child TB cases detected, and only 1/3 in children under 5. Touching on diagnosing TB infection, you're all familiar with the TST and its pros and cons. Important, I should highlight that a TST is not, we often talk about its poor specificity, but it's not completely sensitive either. We know that up to 30% of children with culture-confirmed TB can test TST negative, which is important that it can't be used as a rule-out test. But false positives have been the main problem in settings with BCG, routine BCG vaccination. It can also be false positive with NTM disease. This has been reduced with more specific skin tests that have been developed and recently approved by WHO. There's new 2022 guidance on the use of these specific skin tests that are now available. And these skin tests incorporate the same antigens that we find in the T-spot TB and interferon gold, quantiferon interferon gold assays, namely ESAT6 and CFP10. They are found in M. tuberculosis, but not in M. bovis BCG, and only in a few environmental mycobacteria. So these antigens are far more specific for tuberculosis infection and are not influenced by BCG vaccination. They are now also available as skin tests, which may be of great use in settings where BCG vaccination is given routinely and access to more expensive blood tests may be limited. It's important to emphasize again that neither of these tests, the old or the new TSTs, or the T-cell assays differentiate TB infection from disease, and they cannot be used as a rule-out test because of their incomplete sensitivity. When we think about diagnosing TB disease, it's always important to be mindful of the differences in disease phenotype and age-related risk. We know that young children are at greatest risk of disease progression, but they also develop a very distinct phenotype with lymph nodes in the chest and higher rates of disseminated disease, especially in the very young. Around just before puberty, the risk of disease development is at its lowest, and then the risk for disease development increases again amongst adolescents. But at the same time, there's this complete switch in phenotype, where adolescents now develop cavitating adult-type disease and not the typical lymph node disease seen in younger children. One of the developments in 2022 is the development of a new diagnostic chest X-ray atlas by the Union. This is a wonderful resource which people should please access. It's freely available online, and it provides tremendous guidance on how to read pediatric X-rays in a very systematic manner, and also provides lots of examples of the different disease manifestations seen in children with tuberculosis. There's been a long expectation that computer-aided detection systems, or CAD systems, will come to the rescue for TB diagnosis. These systems, CAD for TB is one of the software packages, have now reached maturity in adults, and they've been endorsed by the WHO for TB screening purposes in adults. Unfortunately, they have not yet been fully tested and adjusted for use in children. And there's ongoing development in this space. But at the moment, none of the CAD systems is fit for purpose in children, especially children with non-adult type disease, so children under 10 years of age. Bacteriological confirmation has always been problematic in young children because they cannot expectorate, and they tend to develop porcibacillary disease with a very variable yield. You are well aware of the different respiratory specimens that can be collected, from a gastric aspirate to an induced sputum to a nasopharyngeal aspirate. All of these provide relatively similar yields, but they're not always feasible to do in a healthcare setting, especially in resource-limited settings. In the most recent handbook, WHO handbook, stool is identified as now an endorsed sample or specimen type for TB detection in children, and it's regarded as a respiratory specimen. In this practical manual on processing stool samples for the diagnosis of childhood tuberculosis, a simple one-step method, the SOS method, which was the method found to be most feasible and with near optimal yields, is described in great detail, and the number of countries are now adopting stool testing using expert. I should remind people to also consider non-respiratory samples. We always want to confirm TB if possible. Fine needle aspiration biopsy remains the preferred method for peripheral lymph nodes, and CSF is important if TB meningitis is considered. The Gene Expert Ultra has been around for quite a while, but it's now been disseminated widely in TB endemic countries, also in Indonesia, and it's the best of our current rapid detection methods for children. This is because the Expert Ultra has increased sensitivity. It's now a multiplex PCR compared to the old Expert, with close to 80% sensitivity compared to midget culture. This increased sensitivity has been achieved by, first of all, having a larger chamber, so a larger volume of sample being tested. It still amplifies the RPOB gene that was used in the first version of the Expert cartridge, which also detects rifampicin resistance if there's mutations. But in addition, it now has two insertion sequences, 6110 and 1081, that are amplified. And if you see that trace reading coming from the laboratory, what the trace reading implies is that the RPOB gene was not amplified, but both or one of the insertion sequences were. This is normally in children regarded still as a positive test and can be reported as microbiological confirmation, although such a result does not provide information on rifampicin resistance. There's also other mycobacterial rapid tests approved by WHO, which I won't discuss in detail. It's important to emphasize that we should encourage everyone to do microbiological testing in children. Not only does it provide diagnostic certainty when it's positive, but getting positive results back builds clinician confidence that you are able to diagnose clinical TB correctly, admitting that yields are not optimal, but it's amazing how it builds your confidence if you see that someone you thought had TB have microbiological confirmation. In addition, if the result is positive, it provides you with very valuable drug resistance information, which can be critical for patient management. In the new operational handbook, there's an attempt using the best available evidence to develop an evidence-based diagnostic algorithm based on a large individual patient meta-analysis. Now, I'm not going to go through the whole algorithm. I'll just quickly emphasize the different steps. It's only focused on children under 10 with pulmonary disease or intrathoracic disease. The first step, as in any systematic approach to the clinical management of a child, is to decide whether this child has critical illness. If the child is critically ill or have danger signs, that child should be stabilized and referred, and not further assessed at that point in time for tuberculosis. Then the next question is whether this child is particularly vulnerable. Vulnerable children are defined as children under 2 years of age, those living with HIV, and those with severe malnutrition. If that is the case, a child with symptoms suspicious of TB should then proceed to have the best available test performed, whatever is available in the circumstances. For older children or children who are not vulnerable, the recommendation is to provide them with a trial of treatment of the most likely alternative diagnosis and to review the symptoms in 2 to 3 weeks' time and only evaluate further if the symptoms persist. But this pathway is only recommended for low-risk children. In addition to collecting a sample, the algorithm also reminds us to get very detailed TB contact information, especially contact in the last 12 months. And you can see how each of these pieces of information lead to a potential decision to initiate treatment. It's only in those where you still don't have an answer where we then end up with an algorithm-based score, which includes signs and symptoms as well as chest X-ray, although there's different scores depending on whether a chest X-ray is available in your setting or not. The intent of this algorithm was really to decrease the case detection gap, to make it possible for people to make a likely TB diagnosis irrespective of the local resources. But a major caveat for this is that when the algorithm was developed, the aim was maximal sensitivity, and the WHO predetermined a minimal sensitivity of 85%. Now, when all the parameters were set and the algorithm was run for sensitivity of 85%, you can see that it provided a very low specificity. This is a compromise that TB programs have to consider. But like I say, the overall intent is to increase access to TB treatment, which we know is really very well tolerated in young children. And now with new treatment guidance of 4 months treatment, which we'll get to, the treatment of minimal disease is very similar to preventive therapy, which is why there's a reduced threshold for TB treatment encouraged really in the new guidelines. In conclusion, regarding diagnosis, I think it's fair to say that despite recent advances, TB remains largely a clinical diagnosis in young children, although there's ongoing attempts to define new biomarkers of TB disease. We don't yet have a golden bullet. It's always important to take a careful TB exposure history. We still require clinical awareness and acumen. You have to think of TB to be able to diagnose TB. We should ensure that children have access to high-quality digital X-rays, not only for diagnosis, but also for determining the treatment duration. We should perform microbiological testing wherever possible. And then lastly, the WHO data-driven algorithm may be used to increase treatment access in remote settings, but we have to acknowledge its low specificity. In a setting like Indonesia, where there's an existing algorithm-based diagnostic approach that's well entrenched, it may be best to only encourage use of the new algorithm under operational research conditions. And those operational research conditions will be provided by TDR. And it would be useful to connect with TDR to see how data can be collected to contribute valuable data to assess the performance of this new algorithm in real life. So moving over to TB treatment. This graph shows the results from a number of trials that were done when the first 6 months TB treatment regimen was finalized, with trials being done by the British MRC in India and in Hong Kong, Marais at the time. What you can see is during the intensive phase of treatment, in adults with smear-positive tuberculosis, with cavities on the X-rays, starting treatment leads to a very dramatic drop in the bacterial load. So most of the organisms, 90% of them, are killed within days. By the end of the first 2 months, nearly all actively metabolizing organisms are killed. But then there are still intermittent or sleeping bacteria that needs to be killed over the coming months. What you can see in these old studies is that after 3 months of treatment, nearly 80% of patients were cured. But clearly, from a programmatic perspective, relapse occurring in 20% of patients is unacceptable. At 4 months, the cure rate was closer to 85, 90%. But remember, this was data from adults with sputum smear positive tuberculosis. So the question has always been whether children with porcibacillary disease can be treated for a shorter period of time. Earlier this year, the SHINE trial published its results, reporting on shorter treatment for non-severe tuberculosis in children from Africa and India. They tested a shorter regimen, which essentially is the same regimen we use in first-line therapy, but with a reduced continuation phase of only 2 months of INH and rifampicin. Non-severe TB was defined as sputum smear negative disease, if sputum was done, intrathoracic lymph node disease without airway obstruction, any other involvement of the parenchyma, but involving less than 1 lobe and without cavities, and then peripheral cervical adenitis. The results showed that 4 months of treatment was non-inferior to 6 months of therapy. In fact, in each of the measured outcomes, the 4-month regimen performed as well or slightly better. Also in secondary outcomes, which included adverse events. So this was very reassuring. Now, done in a large number of children, more than 1,000, with good confidence intervals. The caveat to the study is that there were no children under 3 months included, so this only applied to children between 3 months of age and 16 years of age. But in that 10 to 16-year age group, there were also very few children. You can see the median age was 3.5 years, with an interquartile range of 1.5 to 7 years, with relatively few HIV-infected children, But otherwise, this study was largely representative, being done in multiple settings around the world, and will really move the field forward. Those regimens have been adopted by most of the major bodies. So the WHO have adopted a 4-month regimen for non-severe disease, and the Union recently advised similar guidance. But you can see that a chest X-ray now becomes important to also influence the duration of treatment. In this instance, you can see lymph nodes in the right hilum. You can see compression of the left main bronchus. And on the lateral, the same, you can see lymph nodes here below and behind the carina. But this feature, the compression of airways, now becomes a marker of a 6-month need for a 6-month regimen rather than 4 months of treatment. So a treatment for non-severe pulmonary TB is used, the 4-month regimen, in cases with hilar lymph nodes without any airway involvement, or in cases with segmental opacification involving less than a whole lobe and without any cavities. In children with whole of lobe or multi-lobe opacification, airway compression, miliary disease, or cavitation, the standard 6-month therapy still applies. The new chest X-ray atlas provides a wonderful guide for how to judge X-rays, with many opportunities to practice your assessment of disease severity. So this is the latest Union guidance for the treatment of children and the regimen to consider. So in children under 3 months, the standard 6-month regimen still applies, with the addition of ethambutol in settings with high rates of isoniazid resistance or high rates of HIV. For children between 3 months and 9 years of age, so these are children who meet that typical childhood tuberculosis phenotype. I think there's consensus that we will now treat for 4 months using the new SHINE regimen, 2-HRZ followed by 2-HR. Those with severe pulmonary TB will still use 6 months. The Union suggests that this shorter regimen can also be considered in adolescents aged 10 to 19. But this is where there's still some reservation, because the study included very few children in this adolescent age range. And remember, when we discussed the disease phenotype, it was apparent that adolescent children develop adult-type disease. And from a treatment perspective, we should regard them more as adults than children. So this is one area where many countries, including Australia, have some reservations and maybe waiting on more data. At the moment, some countries have adopted guidance saying that adolescent children, a 4-month regimen can be considered, but only if that was discussed among an expert group. Another emphasis that's now part of the not only the WHO handbook and guidance, but also I think of global awareness, is the need to be aware of post-TB lung disease. This is a main theme in adults, but it's also something of growing importance among children. On the whole, the impression has always been that children recover quite well from TB treatment without major sequelae. But clearly that can occur, and we should collect better data to have a better understanding of what these post-TB lung sequelae are and how to deal with them. You can see that there are now clinical standards that's being developed for the assessment, management, and rehabilitation of post-TB lung disease. I'll stop there. Thank you for your attention.
Thank you, Professor Marais, for the comprehensive lecture on the innovations and advances for the diagnosis and treatment of TB in children. And now let's move on to the second speaker. We would like to invite Dr. Philipp Ducrot. Dr. Philipp Ducrot will give us a lecture on the comprehensive approach for TB elimination. And it's my pleasure to introduce Dr. Philipp Ducrot. Dr. Cros is an infectious diseases specialist with more than 15 years of extensive clinical and public health experience and over 10 years experience in the management of TB-HIV programs. He has worked as a TB-HIV advisor and supported program implementation and research in a range of settings. He has worked with MDR-TB program across Tajikistan, Uzbekistan, India, Myanmar, Uganda, Swaziland, and Zimbabwe. Dr. Cros' work has a strong focus on research, in particular in the development of short-term treatment regimen for MDR-TB as head of the mentioned unit at MSF in the United Kingdom from 2010 to 2017. In addition, Dr. Cros is an expert member of both the WHO Guidelines Development Group for isoniazid-resistant TB Guidelines and the European Research Initiative for Tuberculosis. Dr. Cros joins the Burnet Institute in Melbourne as an infectious disease specialist in the TB Elimination and Implementation Science Working Group, supporting program implementations and research activities. Please welcome Dr. Cros for your presentation.
Selamat pagi. My name is Dr. Philipp Cros, and I'm happy to be able to present to you today some thoughts around tuberculosis elimination in 2022. I'm briefly going to cover key aspects around what progress has been made, what is required to achieve TB elimination, and a few thoughts on some key topics around active case finding, drug-resistant TB treatment updates, and TB preventative treatment. We know from the modelling for the WHO NTB strategy that progress towards TB elimination has been slow, with a gradual decline, as shown in the red line, of 1.5% incidents per year. And if we are to achieve the NTB goals of achieving TB elimination by 2035, then we'll need to be looking at optimizing the use of current tools, but also introducing new tools and new strategies to radically reduce the rates of TB incidence and transmission. But how have we been doing? Well, if we look at the progress towards TB elimination, we are far from achieving the interim milestones of 2025 and not on track. And this is partly due to COVID and partly a lack of scale-up of interventions that we know work. We can see here that the global trend in case notifications reduced in 2021 and has not yet recovered back to pre-COVID levels, and we are now looking at 3.5 million missing cases, with performance in 2021 similar to 5 years previously in 2017. And the mortality rate has increased for the first time in over a decade, particularly in the Southeast Asia region. And if we look at TB preventative treatment, particularly in those over 5, we are a long way from achieving the targets, with only 3% of the targets set for 2022 in treatments of TB preventative treatment offered to those over 5 having been achieved. So very slow progress indeed. But what is required if we are to achieve TB elimination? So I'm just going to go through a schematic here where the red people represent those with active TB disease who are sick and infectious. The orange represents those with TB infection who have no manifestations of their TB apart from positivity on a tuberculin skin test and who are not infectious, but subsequently could reactivate and develop active TB disease, and those in grey who do not have TB infection. And in a standard TB program where the majority of resources is focused on passive case finding, what happens? Well, those people who have symptoms and attend healthcare may get diagnosed and put on treatment, but there are many more people who have active TB disease in red who take a long time or never attend healthcare facilities and don't get diagnosed. And so transmission continues. In addition, some people with TB infection will reactivate and go from orange to red and develop active disease and become infectious. So transmission continues and is not interrupted. If we do active case finding, then more people with active disease are diagnosed out of the total. However, we still see people with TB infection developing active disease, and we haven't fully interrupted the transmission cycle. So we really need to think about models of care that implement active case finding and preventative treatment to be able to interrupt ongoing transmission. The question is how to be able to implement this simple schematic into the real world, which is obviously much more complicated. What we need to be thinking about is the right strategies to interrupt transmission. We need to be searching actively and testing with the right tests to find all TB cases. We need to be treating effectively with the right treatments and providing support throughout treatment. And we need to be looking to prevent exposure and to treat those who have been exposed and developed TB infection with the right treatment. And this is summarized in a Lancet series, How to Eliminate Tuberculosis, from 2015. More recently, there has been a suggestion that we need to go further than just medical models, and this is a model adapted from Dr. Ian McKay's model to tuberculosis by Dr. Jennifer Furin and Dr. Madhu Pai, looking at the Swiss cheese model. The thinking is that there is no single intervention that is perfect. Each of the interventions that we do for tuberculosis has flaws, and we need to implement a multitude of comprehensive interventions across societal, personal, and healthcare system aspects to be able to have an impact on the epidemic if we really are going to achieve elimination. We also need to keep in mind the spectrum of TB disease. We often think about TB in a binary form of active TB disease and TB infection. However, there is also a spectrum in between of subclinical TB disease or incipient TB, people who have no symptoms or don't report or note symptoms, but actually have ongoing TB disease and maybe infectious, and they also need to be looked at being diagnosed and put on treatment if we are going to achieve TB elimination. And we can see here in this schematic where some people who develop TB infection will actually go on to have a cyclical disease where they only intermittently achieve having the onset of symptoms above this blue dotted line, but are often subclinical and they may have a variable course, or others who may have a slow, gradual worsening and eventually develop symptoms. And so we need tools to be implemented that will diagnose these cases. But what proportion of TB is subclinical TB? This is from a systematic review looking at prevalence surveys, and of all bacteriologically confirmed cases, the overall median across all of these prevalence surveys was 50%, had subclinical TB, but the range was quite variable between 36 and nearly 80%. And you can see for Indonesia, it was here just over 40% out of the prevalence of 750 per 100,000. And this means we need to be thinking about using the right tools. We can see here that if we look at using a screening questionnaire, such as screening for prolonged cough more than 2 weeks, then the specificity might be quite good. However, the pooled sensitivity is actually low, with the majority of people with active TB disease being missed. However, if we look at employing chest X-ray and all of those who have abnormalities suggestive of active TB are included, then we improve the pooled sensitivity with only a small reduction in the pooled specificity. And if we combine chest X-ray with a diagnostic test that has high sensitivity and specificity, such as molecular tests like GeneXpert, then we can greatly improve the diagnosis not only of all active TB disease, including those with subclinical disease. So now if we look at active case finding, I just wanted to talk briefly about a couple of randomized controlled trials. Firstly, the ACT-2 trial from Vietnam looked at contact tracing for nearly 11,000 people in 70 districts in Vietnam. And for those where contact tracing was done in addition to passive case finding, then the districts that had active case finding had a 2.5 times higher rate of diagnosis of tuberculosis. A follow-on study, the ACT-3 trial, looked at over 90,000 people in 120 villages and did a comparison of annual screening with sputum and molecular tests versus passive case finding. And in the villages where active case finding was done with sputum collection, there was a 46% reduction in TB prevalence and also a reduction in transmission to children. So how does this work in the real world? So colleagues from University of Gadjah Mada have been implementing a comprehensive program called the Zero TB program in Yogyakarta, including active TB screening, household contact tracing, TB screening in the posyandos, and also TB preventative treatment with shorter regimens. This is a project that's been funded through the Stop TB Partnership and also through the Australian government, and is a collaboration with University Gadjah Mada, the Burnet Institute, and the Dinas Kesehatan from the Yogyakarta City and Kulon Progo regencies. And this involves mobile chest X-ray provided in buses or vans that go out to local villages to be able to do screening. People are notified of when screening will occur several days in advance and are provided with information about what will occur and that the screening is free and encouraged to get TB screening. Screening is performed by chest X-ray, and the chest X-ray is read by a computer software. There are several of these available. We are using the QXR TB software by Cure.ai, which is a point-of-care chest X-ray reading software that gives a score from 0 to 100 of the likelihood of this chest X-ray having TB. And for those who meet the screening cut point, then they are asked to provide a sputum test that is sent for GeneXpert testing. Now, over 45,000 people were screened in just over a 1-year period. 6,500 had presumptive TB, either by symptoms or by chest X-ray. And of those, 577 had had TB diagnosed. Now, if we look at the cascade of TB, those estimated to have TB through to those who complete treatment and achieve recurrence-free survival, this is just an example cascade from India from a few years ago, but we could see similar if we mapped this out for Indonesia or other countries within the region. And we can see that at each stage of the TB cascade, there are people who are lost along the way, and we need to see how we can reduce those losses. Active case finding helps with one part of the TB cascade, but we need to look at what are all the causes for loss of people along the TB cascade. It can be anything from stigma to financial barriers, lack of awareness, HR, human resources issues, lack of adequate staff or training, and how do we support people to ensure that when they start on treatment, there aren't substantial costs, or that we diagnose side effects early and provide effective management for side effects to help people complete treatment. We need strong guidelines and policies, political engagement, and public and private partnerships to help achieve a reduction in the losses along the TB cascade. So just moving attention to drug-resistant TB, which has been particularly hard to treat until recently. WHO has recently announced through a rapid communication updated guidelines, which will be released in December. And they recommend that now drug-resistant TB, rifampicin-resistant TB, should be treated with novel 6-month regimens with 3 or 4 drugs, including bedaquiline, pretomanid, and linezolid, plus or minus moxifloxacin. An alternative is a 7-drug, 9 to 11-month regimen, and for some people, they will still need long 18 or more months of individualized treatment. The 6-month regimens was based on a couple of randomized controlled trials. This is the data from one of those trials, the TB Practical trial, that compared 3 different regimens of 3 or 4 drugs versus the WHO standard of care. And you can see here that each of the 3 different regimens of 6 months achieved a non-inferiority in the per protocol analysis and superiority in the modified intention to treat analysis. So 6 months was at least as good, if not better, than the WHO standard of care. Just talking briefly about TB preventative treatment, WHO has advised a number of options for treatment, ranging from 6 to 9 months of daily isoniazid to 3 months of once a week rifapentine and isoniazid, to shorter regimens with 3 months of daily isoniazid and rifampicin, and even a daily 1 month rifapentine and isoniazid. These are all supported by clinical trial evidence. For drug-resistant TB with rifampicin resistance, there is the option of a 6 months daily treatment with levofloxacin. All of these regimens are estimated to have 60 to 90% effectiveness at reducing progression from TB infection to TB disease. Recently, some colleagues did some modelling looking at a program in Papua New Guinea, in one island, and modelling out different treatment options. So we can see here in this setting where there was high rates of TB and drug-resistant TB, that if we just continued doing passive case finding, then TB stabilised and we did not achieve TB elimination. If we added in household contact tracing, we get a small reduction over 5 years. To this, if we add in population screening, active case finding, then we get a further reduction. But to really radically reduce rates, then we need to add in both active case finding in the community as well as adding in preventative treatment. And in this setting, looking at offering preventative treatment to all people with high risk in the community, with community screening and TB infection diagnosis in the whole community, led to the most rapid gains and the lowest cost over 5 years. So in conclusion, we can achieve faster reduction in TB if we're using the right strategies that are comprehensive and, like the Swiss cheese model, looking at how through a multitude of interventions we eliminate gaps and people are not lost in the cascade. We need the right tools in a comprehensive strategies. We need to identify the major program gaps within each context and see how best to address these gaps within the context. For Indonesia, that means looking not just at a whole country, but looking at the gaps that might be different, and in areas like Yogyakarta that might be quite different from Papua Province or Sumatra. And we need to adapt our response in different parts of the country. We need improved treatment for drug-resistant TB and to use the regimens that achieve 89% success in 6 months of treatment. And we need to scale up TB preventative treatment and stop having partial programs that will only see a partial response. Thank you very much. Terima kasih.
Terima kasih. Thank you, Dr. Cros, for the very interesting presentation. And now we will invite the third speaker, which will be Professor Natalia Probandari. And let me introduce for Prof. Ari Probandari. Prof. Ari is a medical doctor with specific training and expertise in public health. She is a facilitator of the WHO TDR Regional Training Center in the Southeast Asia region on implementation research. Her research focuses on the implementation research of disease control programs, program evaluations, and health systems. Professor Probandari currently serves as head of public health doctoral study program at the Faculty of Medicine, Sebelas Maret University, Solo, Indonesia. She is a doctor and holds a Master of Science in Public Health and PhD from Umeå University, Sweden. She is also a researcher at the Center for Tropical Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah, Mada. She has experience as a WHO technical assistant consultant for developing a national action plan for the control of sexually transmitted disease, the Indonesian Ministry of Health for developing a national plan for tuberculosis control. She has also written several books and has many publications. So please welcome Professor Ari Probandari. She will give a lecture on the pandemic recovery on the TB-HIV and will present her project about the DOMINO project. Please, Prof. Ari.
Thank you, Dr. Rina. Thank you very much for the organizing committee for inviting me as a part of the DOMINO study project team to share our preliminary findings. I am Ari Probandari. I represent the collaborative implementation research team that consists of researchers from several institutions in 3 countries. Right now, the DOMINO project actually is in the last period of research. We developed the proposal in the early 2020. And then now we are working with the final analysis. So in this forum, we would like to present the preliminary findings from our study. So the DOMINO study actually start with a concern about COVID-19 pandemic that will impact to the not only health aspect, but also economic and social disruption. So while the services perhaps focus in the COVID-19 mitigation, but when we develop this proposal, we believe that actually there must be also the impact for non-COVID-19 health services like TB-HIV. So that's why when we start this study, we aim to provide the evidence about the impact of COVID-19 outbreak on the access of delivery of TB and HIV care in Indonesia. Specifically, we describe and compare the cascade of care before and during the COVID-19 pandemic in both services of TB and HIV. And we also identify patient and clinic level factors that associated with health outcomes during the pandemic. And lastly, we also intend to explore the experience and responses of patient and health workers related to care disruption. In this session, I would like to emphasize on the preliminary findings about the cascade of care before and during the COVID-19 pandemic, as well as the description about the patient's factors and also health services level factors that related to the comparison of the cascade of care, as well as explore the experience of the health workers related to the mitigations during the COVID-19 pandemic on TB and HIV services. So our study particularly applied mixed method study. So we applied historical cohort study and also qualitative study as the additional component of the design. And we start actually for the data collection in 2021 to 2022. And the study location are in two cities, Yogyakarta and Bandung. We collected particularly the secondary data from TB information system, which is SITT and SITB, as well as the HIV information system called SIHA. And we also conducted in-depth interview among the patients and also the health workers related to the TB and HIV services. In this presentation, we would like to present only the findings from one city. So let's start with the TB cascade. Our analysis showed that there is a discrepancy in several aspects of cascade of care in TB services. So we define the cascade of care by three categories. First, the period of the started treatment. The second is the completed treatment, and the last one in the treatment success. So we compare the data of pre-COVID, which is the year of cohort 2018 and 2019, with the similar register with TB in 2020 and 2021. The register in 2020 and 2021 is entitled as during COVID period. So we can see here there is a discrepancy of absolute numbers of TB patients that started treatment. Also, the decrease of the absolute number of the TB patients that completed treatment, as well as the TB patients that experienced treatment success. And if we try to link between these three components, we make 100% as the total TB patients that started treatment. We also found there is a decrease of the completed treatment proportion and treatment success rate during the COVID-19 pandemic compared to the period of pre-COVID-19 pandemic. So we can see here, there's a drop, particularly about the cohort of the TB patients that completed treatment during the COVID-19 pandemic, as well as the treatment success. So we estimate only about 62% of completed treatment rate and 57% of treatment success rate, compared to 96% of completed treatment in the period of pre-COVID and 89% in the period of during COVID for the treatment success rate. So our qualitative study also tried to explain that phenomenon, and we found that actually there is a pattern of fear of being diagnosed with COVID-19 in health facilities among the TB patients that actually hinder the opportunity to have proper diagnosis and treatment. And also because of some restriction related to the services during the pandemic that also influenced the number of patients that visiting the health facilities. That's why there is a decrease of the absolute number of TB patients that started treatment. And also, when we ask the patients and also the health workers about the reasons for barrier in completing the treatment, there are also some informations, for instance, about the increase of the number of the TB patients that out of town that should be referred to other city because of the they have to move from this city to their original city, the original home country. And also because of the reluctance of the patients due to mobility restrictions and also fear of being diagnosed. So we found that actually fear of being diagnosed with COVID-19 also some barriers for treatment completion. And when we explore about the barriers of the treatment success, we also found that actually during the COVID-19 pandemic period, the health worker monitor the selective patients that come to the health facility. While the treatment monitoring is perceived better, but it also can be reflected that this opportunity for treatment monitoring is larger among the patients that actually come to the health facility. So we call it selectivity. And also because of the restriction of the number of patients, that's something related to the opportunity of treatment monitoring by the healthcare workers. In addition to that, we also found that actually the TB services and also the health workers conducted many strategies to mitigate the impact of COVID-19 pandemic to health services for TB patients. So we found actually 4 types of mitigation. First, about the home delivery. The second is about the treatment monitoring, service flow, and telemedicine. So particularly during the COVID-19 pandemic, health workers try to deliver the medicines to the TB patients through TB cadres and also by themselves in the home of the TB patients, particularly for the TB patient that do not attend the scheduled appointment. And the health workers also call the patients and use many strategies of communication like WhatsApp applications to contact the patients and do the treatment monitoring. And also because of the change of the service flow due to the COVID-19 pandemic, there's also some adaptations of the procedure for TB patients. And they also conducted like separation of visiting days and room between TB patient and COVID-19 patients. So this is some mitigation of TB health services by healthcare workers during the COVID-19 pandemic. We also conducted the same analysis for HIV services. And for the HIV cascade, we also find similar pattern. The discrepancy of absolute number of TB patients that linked to care, started treatment, retained in care, and adhere to treatment between pre-COVID and during COVID period. So because of the fear of exposure of COVID-19 in health facilities, there's also some barriers related to the number of HIV positive patients that then register in the HIV services. So in addition to that, there is also healthcare facility barriers because of the different health facility for diagnosis and starting treatment. That's something also can decrease the opportunity for HIV positive patients to be registered. And the reduced time taken for counseling for the patients, that's also something that we found during the COVID-19 pandemic. And the other barriers also about the reluctance of the patients to go to health facilities because of the fear of getting COVID-19. So I think this is something similar pattern if we compare with the finding with the TB patients. And for HIV patients, patient also move due to job loss, and also similarly because of many HIV patients also take the education in the university. So the change of the modes of the lectures to online mode also then induce the out migrations of the HIV patients to other city, and also fear of exposure. That's something also as the barriers of the retain in care for HIV patients. For the adherence to treatment, that's the total HIV patients that in 2 months consecutive, 2 consecutive months still receive treatment, plus that more than 95% of adherence in the first 2 months. We also found in the cascade of care the decrease of the proportion of HIV patients who adhere to the treatment if we compare in the period of COVID-19 to the periods of before COVID-19 pandemic. That's also because of the fear of getting COVID-19 and also about the low awareness for treatment among the patients. Similarly, actually the healthcare worker conducted some mitigations related to the impact of the COVID-19 pandemic to the services, like multi-month dispensing. That's something that was the policy of the MOH, and also the home delivery. They provide the medication delivery by online motorcycle, taxis, or also the help of the peer companion by NGO. And high loss to follow-up of patients actually has been mitigated by the tracing mechanism carried out by peer support by NGO for the most patients who live outside the healthcare facility area. And similarly with the mitigation in the TB services, For HIV services, online registration and consultation are also the two strategies that have been conducted to try to improve the services in the situation of COVID-19 pandemic. We also find some challenges in this study. This is something that we would like to share when we conducted the historical cohort by collecting the existing TB and HIV information system. We faced the challenges about the quality of the data, like incomplete ID, duplicate ID, and missing outcome data. And we conducted some strategies to improve that by recheck the health facility, develop new ID, check for ID duplications, and also some other technique to address the duplicate ID, as well as the recheck with health facility. And finally, in conclusion, this project provides evidence about COVID-19 pandemic on TB-HIV cascade of care. The second, that we found actually restricted mobility and fear of COVID-19 exposure has limited patient access to TB and HIV care. And we also observe variety of interventions have been implemented by health workers, by peer supports to mitigate the impact of COVID-19 on TB and HIV services. And right now we are still in the periods of analysis of the effectiveness and cost effectiveness of those interventions. So in general, the lesson learned from the DOMINO study hopefully can be something that we can improve for the post-COVID-19 pandemic periods, as well as to improve the resilience of our healthcare services in the future. So thank you very much. I would like to also acknowledge the National Institute for Health and Care Research, United Kingdom, for funding this project. Thank you very much for your attention. Back to you, Dr. Rina.
Thank you, Professor Ari, for the very interesting findings from the DOMINO study, how we can see the impact of COVID-19 to the cascade of care for TB and also HIV. So we come to the session for discussion, and I invite Dr. Philipp, please, to join us. And I have information from the organizing committee that Professor Marais unfortunately cannot join us lively. So here we have some questions, but this is for Professor Marais. So this question will be sent to Prof. Marais and will be organized by the organizing committee, and the answer can be accessed in the ICTM website. And we haven't had, So we have question for Dr. Dr. Cros for TB elimination. We done contact investigation to find any transmission among household contact and close contact. Based on my experience in our health facilities, we done investigation only for pulmonary TB patients with a positive smear. Should we done the investigation among pulmonary TB patients with IFB negative but just X-ray positive too? This question is from Sylvester Sikora. Please.
Thank you so much for the question. And it's a really good question. So maybe just a couple of comments. Firstly, in terms of active case finding, household contact tracing is very important, but it's estimated that only between 10 to 20% of transmission of TB happens in the household. So household contact tracing is important, but you will still miss a lot of where new cases are occurring. Maybe the second point is that when doing contact tracing, like household contact tracing, it's always a balance between the amount of resources and the yield that you get. So the focus on guidelines has been on doing active case finding for those who index cases are smear positive or bacteriologically confirmed, because the yield in the household will be higher. If you follow up and also do contact tracing for those who have index cases that are AFB negative, you will still find some TB cases, but the yields will be lower. So the question then is a programmatic question: how best to use your resources and how many resources do you have? Given in Indonesia, like in many countries, the contact tracing in households is not done 100%, even for bacteriologically positive, then the focus should be on the bacteriologically positive cases, the index cases. I think the one difference is when you're talking about finding a case amongst a child. In that case, you should do household contact tracing, not because the child is infectious, and regardless of whether the child is microbiologically confirmed or not, because you might find cases, index cases, in the household of the child.
Okay, thank you, Phil. I think that's very clear. And I would like to continue the question about the contact investigation. Maybe this is related to children and adolescents. Yeah. So now TPT is extended to be given to children more than 5 years of age who are in close contact with case of pulmonary TB. It is recommended to perform chest X-ray or sputum smear to all children above 5 years of age in the WHO guideline, or performing chest TST before giving the TPT. But we know that TAST and also chest X-ray will not be available largely, in particular in remote area in Indonesia. So what you think, or what's your experience of giving TPT directly to all of the household contacts without any test for the asymptomatic contacts? Will it be cost effective, or which one is more harmful or beneficial for the program and also for the individual?
Thanks, Rina, for a great and a difficult question. So I think it's a great question because we don't know what the best models of care in different places actually are. And I think that's why your colleagues and yourself at UGM are doing some of the operational research that you have ongoing. There are sort of some advances that maybe help us. So having handheld X-rays like the Fuji X-Air, and having shorter TB preventive treatment like the 3-month regimens, which is taken once a week with rifapentine and isoniazid, I think help a lot. The question really comes down to, how do we minimize the side effects from TB preventative treatment by giving it to only those people who need it? If you start to have shorter treatment, and even shorter treatment that has less side effects, then that question and the balance changes. So there is a WHO approved regimen that's only 1 month of treatment of isoniazid rifapentine taken daily. And I think if we start to move towards shorter regimens like this, then maybe we can do away with doing the TST or the IGRA test and treat everyone in the remote areas. I say maybe we can because I think that needs to be assessed by operational research. Current WHO guidelines says
Recording in progress. Recording in progress.
Because now in Indonesia, we started to scale up for the TPT provision for all ages, and we have problem with the lack of the logistic for TST in particular. So people just they are encouraged to follow the guideline, but in the field we do not have that one, so it can hamper the scale up for the TPT provision for all ages of the contacts. Thank you. And we have one question from Pak Sylvester again. This is for Prof. Ari. Prof. Ari, thank you for the knowledge and presentation that's shared. And he asked question, based on your experience during DOMINO study, are there any intervention or advice that we can do in order to enhance TB program towards TB elimination? Please, Prof. Ari.
Thank you for the questions. So from the findings of the DOMINO study, actually we learned about many intervention. We call it intervention to mitigate the impact of the COVID-19 to the services. Among the interventions, I think actually we can learn that health workers actually would like to conduct the services by more active strategy, like doing home delivery for the treatment, as well as for teleconsultation through online mode or media, and using any innovative communication strategies. And we also learned that actually during the COVID-19 pandemic, the healthcare workers would like to have collaborations with other institutions or other even non-government organizations to provide the best services for the patients. So I would like to highlight also what Dr. Philipp already mentioned in the talk about the importance of the collaboration between public and private institutions, as well as the non-government organization in delivering the TB services. So I think that's the first important strategy that we have to emphasize for achieving TB elimination. The second one is the use of innovative and also user-friendly communication mode for particularly educating the patients and also giving the counseling to the patients to improve the compliance of the patients to the treatment. So I think that's also something that important to be more developed and also to be more further implemented, even post-COVID-19 pandemic. Thank you.
Thank you, Prof. Ari. I think that's very clear. And we still have time actually for about 10 minutes. So I invite participants who want to talk directly to Dr. Tukro and Prof. Probandari. Please raise your hand. Okay. If not, while waiting for the question, I would like to ask about I think there was one interesting finding in your study, Prof. Ari, about the incomplete data from the national reporting system. And I think that's a big problem that we all already acknowledge about that. And do you see any, and I know that Prof. Ari, you are familiar and have been deal with the data for long times in Indonesia. you see any improvement in the data collection or reporting and recording now, and what is the big problem for Indonesia, I think, to be improved, at least to lessen the gap of missing data because of the underreporting. Yes.
Yeah, thank you, Dr. Rina. From my point of view, I think the things that the government should do for improving the TB information system is the integration among the TB information system in the SCTT with the ones perhaps in the existing, let's say, hospital or other health facility information system. So I'm glad actually to welcome the initiative of the government for the integration of the TB information system through ASIC application. So we really hope that the integration with the ASIC is something that promising in the future to improve the quality of the data. But also, I think the infrastructure for supporting that kind of implementation, that's also something important. So let's say that the barriers that we found related to the quality of the data, particularly about the load of the TB staff to enter in the data in the system. So they have two systems. They still have the offline, the paper-based information system, and also the online one in the SCTT. But now the change of the behavior of how to record and reporting the data, that's something also that we should take into account. So in the future, when the government initiate the integration, I think we have also should prepare about the infrastructure as well as the change of behavior, the working with the information system among the human resources in the health facility. That's all, Dr. Rina. Thank you.
Thank you, Prof. Ari. And Phil, maybe you have any insight based on your experience in other countries, which we can have lessons learned from them to improve the recording and reporting in TB in Indonesia. Yeah. Do you hear me, Phil?
No, my internet just dropped. Do you mind repeating?
Yeah, this is about the recording and reporting. It will be great if you can share your experiences from other countries, the good lesson learned from them that we can conduct it in Indonesia to improve our recording and reporting.
Thanks. I mean, I think my first point was the one that Prof. Ari already made, which is about not having too heavy a burden of data collected for the people who have to record the data. So there's always a balance between how much data do we really need to collect and intermittently reassessing that data that you have been collecting, because sometimes as programs change, the data that you're collecting from you decided 10 years ago is some of those variables you don't need. I think the other thing that's really helpful is feedback loops. So very often people are asked in programs when they're working very hard to also fill in data that goes into a database that gets sent up to people elsewhere. And the people elsewhere do all the analysis and tell people what's going on. And so people in the program who are entering the data don't have the opportunity to analyze the data themselves. So I think it's really important that people in a Puskesmas can regularly use the data system to see, well, how is our program doing? So at the TB unit, they can analyze it and see, well, we're doing well in this aspect or not in this aspect. How does that compare with the other sub-districts around us? How does that compare now when we look at the private system? And so being able to not only do your own analysis, but to see locally how you're doing, to learn lessons locally on how you can do better, I think is important. So those feedback loops means that there is a need for some people to be doing analysis, but there needs to be information coming back saying, you're doing this well, this is not being done. And I think also some ability to do your own analysis within the system, at least on your own data, is important.
Okay, thank you, Phil. I think I absolutely agree with you, and that was what we observed in the field, yeah, Prof. Ari, about the analysis. We reached of data, but we did no analysis at all, almost not did the analysis, and I think that's a pity for us, and this is also an area that we have to improve. We have one other question for Prof. Ari. So she thanks to all the speakers for the very enlightening talks. And for Prof. Ari, or maybe Phil, you can also answer. The question is that I have a friend with HIV from which their first health facility, they were not given TB prophylaxis regimen. Then they move for work, and then in the new health facility, the prophylaxis is given. Are the procedure different from each health facility? And I would like to give appreciation to all the healthcare workers as well as researchers who have dedicated their work in HIV/TB. Thank you so much. Yeah. So it's about the different care among health facilities. Please, Prof. Ari.
Yeah, thank you. So it should not be different standard actually, because people with HIV is the priority group that should receive the TB preventive treatment. That's the standard. So I think perhaps the problem here, not all health facility actually know about that standard or have been provided by the TB preventive treatment logistic properly. So I think that's also something that now the government, I think, try to catch up in effort to achieve the TB elimination. So that's my short answer. Thank you.
Okay, thank you. Yeah, I think that's clear. Yeah, Phil, you have additional comment for that?
I think the only thing that I would add, I agree with everything Prof. Arya said, and maybe just to add that when we think about TB prevention, it's important to think about how do we have systems for reaching those most in need. And I think the cascades that were shown in Prof. Ari's presentations as well as mine are really important for facilities to look at. Where are we missing people? And how can we find out how to improve in our own system, how to find people and make sure that everyone who's eligible according to the national guidelines receives the proper diagnostic assessment, receives the proper treatment that they're prescribed. And so, people living with HIV and children have been the key high-risk groups for a long time, and many countries have failed to reach the targets. Now that we're expanding TB preventative treatment, we're finally doing a little bit better with children and people living with HIV. It's encouraging to hear that the second facility did provide it, but we really do encourage facility staff to look at how they can do better at their own cascade and see where they're missing patients and people and how they can better implement guidelines. And maybe that's also where implementation research comes in, which Prof. Ari can speak to better than I can.
Okay. Yeah, thank you, Phil, and also Prof. Ari. I think that's the last question for all of the speakers. And for the last session, I take some notes from 3 speakers. So first from Ben. it is still challenging to make a diagnosis of confirmed tuberculosis, bacteriologically confirmed tuberculosis in children, but it is possible, and it is, we have to do our best to perform the bacteriological tests for children, because now the cases of drug-resistant TB is increasing, and also it is to improve our confidence. And clinical diagnosis of TB is also challenging, but we have to also consider about the harm and benefit to make a decision whether we will treat or not to treat children. And it's a good news for us in the field of child TB that a shorter regimen of TB for 4 months for mild TB is now available. So it's not too long for parents to give drugs to children. And from Dr. Cros' presentation about how to achieve TB elimination, so the right strategy, which is comprehensive with right tool, is important. And we have to identify the program gaps and also the key intervention that we can do to solve that gaps. And then scaling up of the good program, including the TPT, is also important strategy to achieve the elimination of TB. And from Prof. Ari talks, we learned that from the DOMINO study, the result of DOMINO study, that how COVID has disrupted the both TB and HIV cascade of care, from the diagnosis, the treatment, both in quantity and in the quality of care that the patients give during the pandemic. Hopefully in the result of this study, we can see which one is the intervention that is effective and cost effective that we can continue to do after the pandemic, and the management of TB and HIV will be better. I think that's all of the session today. Thank you very much for your attention and for the participations from the participants. Thank you and have a good day, everyone.